in terms of the lung cancer space, CNS metastases, as I mentioned, occur in up to half of all non-small cell lung cancer patients. So the ability of an inhibitor like 1535 to reach the CNS as well as to potently inhibit EGFR mutations is really critical for it to reach its full potential. We think that 1535 will differentiate from currently approved EGFR inhibitors in patients with lung cancer in two key areas. First, in those with tumors expressing intrinsic resistance mutations. Those are also known as uncommon mutations. And as well as those who have acquired the C797S resistance mutation after treatment with irreversible third-generation inhibitors like osimertinib and lazertinib. So in the intrinsic resistance space, about up to 30% of all non-small cell lung cancer patients have tumors that have tumors driven by EGFR mutations. They don't respond, or they only respond for a short period of time, less than a few months, to the approved EGFR tyrosine kinase inhibitors. And this is believed to be because of what we call these intrinsic resistance mutations. One of the most prevalent of which is the G719X mutation. And that causes an altered P-loop interaction with the EGFR inhibitors. 1535 was specifically designed to address those changes. The second generation EGFR inhibitor, afatinib, is actually approved for the treatment of these uncommon mutations, but it isn't brain penetrant, and therefore it's going to inadequately address CNS metastases. Osimertinib, which, as I mentioned earlier, is CNS penetrant, so it's a third generation inhibitor. It's not approved for uncommon mutations, but it is part of the NCCN guidelines to treat those mutations. But the trouble with osimertinib is it isn't broadly active against all of the uncommon mutations. And 1535 has potent anti-proliferative activity against both the most prevalent as well as the less prevalent of those uncommon mutations, with, again, an average IC50 of less than 4 nanomolar and over 100-fold average selectivity over wild type. And finally, in the acquired resistance space, osimertinib, because of its ability to prolong survival in lung cancer patients and because of its favorable tolerability compared to the first and second generation inhibitors, is now commonly administered as a first-line therapy in patients expressing either the exon 19 deletion or the exon 21 L858R canonical EGFR mutation. So on-target acquired resistance to these third-generation irreversible inhibitors like osimertinib can occur via mutation in the EGFR kinase domain. An example is the cysteine 797 to serine mutation. And that renders osimertinib a weak, reversible inhibitor of EGFR. Like osimertinib, 1535 is also a potent inhibitor of the exon 19 deletion and the exon 21 L858R canonical EGFR mutations. But the difference is that we designed 1535 such that its covalent warhead is able to retain the ability to react with the serine as well as the cysteine at the 797 position. So that means that 1535 is able to inhibit the acquired resistance mutations such as C797S that leads to resistance in some patients treated with first-line osimertinib.